Bonjour, bonjour à tous, je suis Olivier Auguste.
Good morning, everyone. I'm Deputy Director of Le Parisien, and I'm very pleased to welcome you here for this session called Is It Possible to Guarantee Access to Health Care? I'll introduce our speakers in a few minutes' time, but I wanted to talk about Professor Habib. He teaches here at Aix-Marseille, and he deals with digital tools in the area of health. You are the coordinator of this session, and in a few minutes, you will talk about the major challenges. Thank you, Olivier. Good morning, everybody. Is it possible to guarantee access to care? This is a very vast question, which is obviously extremely important. And unfortunately, it's a burning issue. There's a crisis in terms of emergency care. There's a lack of drugs, a lack of caregivers. This hits the headlines constantly. And our health system is therefore very fragile. Now, the weaknesses were highlighted by the pandemic, its intensity and its sudden arrival. There are structural difficulties we are familiar with, an increase in demand, a deterioration in the offer of care. The number of doctors hasn't increased by any means, and to that there are new and further difficulties which we hope might be passing, but that is not definite at all. There has been a breakdown in the supply chain of pharmaceutical companies. There have been multiple waves of epidemics, and there's health professions no longer attract the same vocations, and so on and so forth. So the health system is very fragile in terms of access to health care. Everyone's aware of the fact. Health professionals, regulators, the population, and this threatens the access to health care. Where the issue is really complicated, it's the fact that there are 20 years of legitimate reforms which have still not obtained decisive results when it comes to access to care. So how can we contend with the difficulty? That will be the goal of this session. Today, we'll talk about the possibility of guaranteeing access to health. Obviously, we can't give a fully fledged answer today, but we'll try better to understand the challenges facing our health systems. And above all, we can try to identify action, because the theme is to recreate hope at this overall session. Before going further, I think we should define what we mean by access to care. This is a multidimensional concept, and I'll sketch it out because we'll wait for the music to stop, perhaps. As I said, there are different dimensions in terms of space, geography, socioeconomic matters, the question of rights, and the economic ability of patients to pay. In terms of the spatial dimension, you have the availability of care in a given territory, how accessible care is. You can distinguish between primary health care, GPs and nurses, secondary care, more specialized health care, and finally highly specialized tertiary care, which is usually given in the teaching hospitals. And you have to strike a balance between these different types of care in order to guarantee proper access. Before I give the floor to our prestigious speakers, our panel members, I'd like to highlight three challenges which I think are essential to guarantee access to care. Three challenges from my stance as a manager. I have specialized in managerial science. The first challenge is quite easy. The ability of our health system to reduce inequalities based on geography or socioeconomic criteria. It's a real societal issue. It's a question of living happily together. We have telemedicine, for example, the various organizations for healthcare. We have all sorts of acronyms which we could refer to. Recent studies, however, show that the health crisis has reinforced geographic and socioeconomic inequalities. That's the first challenge. The second challenge concerns our ability to prepare to cope with new major crises, future major crises, because, as we know, these crises may bring about totally unknown situations when it comes to a breakdown in the access to care. As a manager, I would like to say that the crisis has highlighted managerial processes which were somewhat neglected or not mentioned, considered accessory, secondary, yet they play a crucial role in crisis management, the management of supplies, inventory management. So if you think about a crisis and organizations that are capable to act in degraded circumstances, you mustn't neglect any of these managerial processes. And finally, the last challenge is a cross-cutting challenge, and it flows from the two first. It's the ability of the health system to operate as a network, to function as a network and not in ivory towers. It's a complex challenge because the health system is very complex. The health system comprises any number of antagonisms, far too many. The private and public or state medicine, centralized or decentralized care. And finally, this functioning, this antagonism, means that the system works in silos. And that leads to bureaucracy, which just doesn't work properly. So to get the discussion going, I would like to mention some questions which our panel members might like to react to. First question: the difficulties we encounter, are they specific to France? What are the factors that explain these new difficulties which are emerging? What are the levers for action that we could use? And I believe there's also a very specific question that pertains to the pharmaceutical industry. What strategy can we set up to avoid these shortages and these breakdowns in supplies in the pharmaceutical supply chain? And finally, what is the place of private players and associations in access to care? I'll give the floor to Olivier. Thank you very much. So, a lot of challenges. We have an hour to talk about all these matters in terms of the access to care. Each of you will contribute his or her viewpoint, his or her experience. I'd like to thank our four speakers for being here, and I'd like to introduce Sylvie Bouillon, doctor, specialist in epidemiology and public health in the World Health Organization. You run the Prevention and Preparedness Department, preparedness for epidemics and pandemics. Thierry Hulot, you're a pharmacist by profession. You run Merck in France, and you're president of LEM. That is, you are the representative of the enterprises within the pharmaceutical industry. Eric Momi, you are a broker for April. And Rosala Miccio, you're president of the Italian NGO Emergency. You intervene to provide care to the underprivileged, those far from the health system in Italy, and we'll also talk about other emergency situations. I'd like to specify that we'll try to keep a few minutes at the end of this session to take some questions, so don't hesitate to prepare your questions. Sylvie Bouillon, I'll start with you. Perhaps you could give us the global view of WHO. When we were preparing this session, we talked about this, and you said that in most of the health systems around the world, the difficulties, the obstacles in terms of universal access to health, these obstacles are similar around the world. Could you explain that? Good afternoon, and thank you very much for inviting me to this discussion. I think that indeed what we see in the world at present is a shortage of health personnel. And there can be no access to care if you don't have enough caregivers, if you don't have enough health professionals. That's a world phenomenon. And obviously there are different gradients. In France, we have 3.4 doctors per 1,000 inhabitants. That's much less than in certain countries where it have more than 5. It's much more than Mozambique, however. It's a problem. In Africa, when you have an Ebola epidemic, If there's less than one doctor per 1,000 inhabitants and the doctor dies of Ebola, then you have a whole region which no longer has access to care at all, even other forms of care. So the shortage of health personnel is a major problem. What we see in France is that there's a downward trend since 2010. There have been minus 1.3% of caregivers. That doesn't look like much, but it's a downward trend, and I do think that we have to take it into consideration. Another problem is geographic discrepancies over and above national figures. There are different situations, of course. There are medical deserts which are appearing following crises, or people leave to retire, and it's very important to follow this as a trend in order to provide a quick solution. And there's another problem that we note in European countries. In the developing world, there's a true structural shortage, which has been around for a long time now in European countries. The problem is the aging of the health personnel, with the risk of an aggravated shortage in the years to come. As the theme is recreating hope, I'm not going to say we're in a critical situation. I believe, however, that it's important to take action now. And we have a lot of work to do. Perhaps you could say a few words about the use of technology, which could be a means of dealing with the shortage of doctors. Yes, absolutely. I think we need to attract young people to these professions. During the pandemic, health professionals were given a round of applause in the evening. For young professionals, applause is not sufficient, however. They need to be given greater regard, and I believe that it's very important, for example, to develop telemedicine. It's a fantastic tool which could provide access to specialized care even if you live in a very remote place. There are other approaches too. Technology when it comes to diagnoses. I think that in the near future we'll be able to make diagnoses at the GP's office. One will be able to screen for various pathogens. You won't necessarily have to send the patient to a lab a long distance away. So I think we could reorganize care, modernize medical practice thanks to these new technological tools. Thank you very much, Sylvie Bouillon. Thierry, we'll look with you at the issue of drugs. Over the last few months in France and in Europe, there have been shortages of certain drugs, very common drugs, paracetamol, for example, and highly specialized drugs which are necessary for the very survival of patients suffering from very serious illnesses, antibiotics, and curare, for example. And we couldn't find these drugs in our pharmacies or in the hospitals. How can one avoid this kind of situation in the future? Well, first of all, I'd like to say that when I began my career as a pharmacist, the last century, I'll put it that way, I would never have imagined for a single second that one day I would speak to a public like you and deal with this topic, which would have been unheard of in the past, like a person in France wouldn't have access to care or to the right drugs. This was unheard of. We've talked about shortages throughout the winter. We've talked about supplies. We've heard reportage from patients, testimonials from patients and from parents who needed drugs for treatment. We've heard from patients who suffer from cancer and who don't have access to certain innovations in France. Yet at the same time, politicians at the last strategic meeting of health strategists, the President of the Republic here, he said, we want to make France the leading country in Europe in terms of health, innovation, and sovereignty. So we have this strategic vision. It's there. And people keep invoking it as something highly desirable. Yet what about the means, the skills, the ability to follow this roadmap? it'll be difficult to reconcile everything. So what did we witness this winter? We saw new Senate missions to look into shortages. There was a ministerial mission that looked into the financing and supplies of drugs. And so one cannot but note that the financing and regulation system, as it applies to drugs, has just started to collapse. It's urgent to do something. I represent the drug manufacturers. We've tabled any number of proposals. Yesterday, I welcomed the fact that the senatorial mission took up a certain number of packs. It's urgent to coordinate drug supplies in France. Drugs, there's an economic aspect, there's the employment aspect, skills, and industrialization. This should be interministerial. We need to have a general secretariat for medicinal drugs. And it's urgent to stop just invoking certain ideas, pious ideas, but France, when it comes to access to drugs, is finding itself in an ever worse situation. A couple of figures. With LEM, we set up an observatory for access, and every 6 months it assesses the situation and publishes it. And after 2 or 3 years, we'll be able to see over time. In fact, what we note is that France is not doing that well. All the other leading European countries are doing better than we are. And the situation keeps getting worse from year to year in terms of access to daily health, access to innovation, attracting new plants, reinforcing what already exists. The solutions are well known. You could give us a few solutions, perhaps. You said you sent in some proposals, you tabled them. Let's look at the future and recreate some hope. A simple solution. With them, we said we need to have a list. We have about 14,000 types of drugs sold in pharmacies. Not all are essential or vital. Which ones need to be protected? If this special drug is not there, then the health status of the patient will deteriorate in an irreparable way. So the Ministry of Health has published a first list of 450 molecules, which is subject to debate, but that's not the issue. The list should be a European one. We published the list, but what are people now doing with it? It's fine and dandy to have a list, but that's not very useful. We have to sit around a table within Europe and analyze the production chain where you have bottlenecks, and we could say that this molecule should be repatriated. We need to protect the plants in Europe, or probably we have to reinforce them in France. We need a real plan of action. What does this entail? Fiscal or regulatory measures? Well, we all need to sit down at the same table together. Let's take a very simple example. I'm a grandfather. We all look desperately for amoxicillin for our grandchildren last winter. It's a bit stupid. The Germans had amoxicillin present. They could send us some on. Well, they didn't. No, because you don't have the same name on the box. You don't have the same packaging. You don't have the same insert. It's not exactly the same indications for essential molecules. You need to standardize things on a European scale. And then we could shift the drugs from one country to another. If you have an insert in German, you can't bring it, import it to France. All you need to do is to have a QR code on the packaging, and that would solve the issue. So we have to make the supply more fluid across Europe. Also, I think we have to be much more simple in our procedures and in terms of regulations. That's the first stage. When it comes to shortages, there are some quick wins. And then you could reindustrialize the country, but that'll take 10 years. For me, the main commitment is that all the stakeholders should stop just talking and sit down together with a common agenda and discuss it in the interests of our citizens. And all the pharmaceutical companies will be there. And let's look at innovations now. We all talk about new cancer drugs, personalized treatment. What do I note in the observatory and its report? France exports mature conventional products. Our share of exports is reducing, but we import more and more biologicals. We're creating our dependence for the future. We have a problem with daily treatment, and now we're becoming totally dependent when it comes to certain other products as well. So this is an emergency situation which we must at all costs try to remedy. Now let's look at the financing of the health system. You're present in any number of countries. You are in contact with many expatriates. In France, we spontaneously consider that it's the health service which provides access to care via the reimbursement of care. You talk about the private sector. Of course, you are a key link. You say that if private entities were given more place, more space to act, this would not necessarily enhance inequalities. Yes, I don't want to contradict everything that's been said. When you talk about access to care, what one notes is that France is in a better situation than most OECD countries. When I say access to care, I'm talking about the population having access to essential care. And then we have financial protection as well. If you look at France in particular, we have a hybrid system. There is obligatory health insurance, the social security, as we call it, and then there are additional insurances. The first covers about 90% or 80%, and then the households only have to cough up 6 or 7%. That's the lowest rate across Europe. So our health system has truly played its part in terms of coverage. It's played its part in terms of keeping control of health expenditure. The network works very well in terms of optics, and things actually work extremely well. We have private insurers in France which play a part when it comes to controlling health expenditure. We have tens of thousands of expatriates around the world, and we have a role in terms of cost containment. We divide the bill by 10 in the US, for example. We really have a part to play. But beyond this, private insurers have an extremely important part to play in terms of the patient pathway and the quality of care. Let me give you a simple example. The second medical opinion. That can improve the patient pathway. It can lead to a reduction in costs. Yet, despite noting this, it's not necessarily very effective in France where there's access to care. Let me give you a figure. 50% of French people are in good health at the age of 65, 77 in Scandinavian countries, so that's the question of the efficacy of the system. Second point, we have the question of territorial inequalities as well. We have medical deserts. Private insurers have taken initiatives when it comes to telemedicine. AXA developed teleconsultation services. It's fighting with the government to develop this, and it works extremely well. So there you have it. Second aspect, we have the socio-cultural dimension. People often talk about recourse. We have the C2S, which enables people in France not to have to pay for their complementary health insurance. The remainder of the population pays only health. If you look at the population, there are territorial inequalities that can be resolved, and there are socio-cultural inequalities which private insurers can help to resolve as well. Because the big difference, well, you're saying you can round off the state-run system. Social Security is a wonderful entity. It talks with the health professionals, but it doesn't know how to talk with the insured parties. We could talk more about prevention later on. When it comes to prevention, we spend as much as other OECD countries. It works pretty well, and insurers in the field have this ability vis-à-vis different groups of people to adapt the health system to their needs, and that's something that the social security system doesn't know how to do. So this is one of our strengths. We have systems which are based on insurance, like in the US, in Japan, or in Switzerland. They work extremely well. Conversely, there are great inequalities. So we're in this sort of an intermediate system, a hybrid system, which can produce far more positive results when it comes to the French people's health. We've talked about bureaucracy, and with Olivier Véran. He viewed the complementary health insurances as something that was overly biased, and this needed to be nationalized and become a more state system, which would be more effective. There are certain ideological barriers we need to overcome. I'm highly optimistic, as I said earlier on, given what the President of the Republic said when he was re-elected. And we can talk about this again later. Thank you very much. Now, with emergency, we'll be talking about your activity in Italy to start with. You are a private entity. You are a non-profit entity. The idea is to make up for shortfalls at the state level. What does the Constitution of Italy provide when it comes to universal access to care? And what have you noted in terms of your action in the field?
Thank you very much. I will speak in English, so I hope this is not going to be a problem. Well, yes, we are very lucky in Italy because the Article 32 of our Constitution states that healthcare is a right of persons and an interest of the community. And this is something that has been at the grassroots of our national health system, public national health system. When it says it's a right of the person, does not mention the citizen. So every single person that is stepping on the soil of Italy has the right to access healthcare. And in addition to that, it states that particularly with vulnerable people, they need to, the barriers that prevent these vulnerable people to access healthcare should be removed. Unfortunately, what we have seen in practical terms, I mean, we work in many different countries around the world, but since 2006, we have started to have mobile and fixed clinics in several regions in Italy, from south to north, that this right, this approach, which was very wise, is actually not implemented in the daily practice. And what we have seen is that the most vulnerable people, those that should be protected by the public system, are those that are left behind.
De qui on parle? Quel type de profil?
Elderly people, so also Italian people, so not only foreigners. Foreigners, documented regular migrants, or even undocumented migrants. Minors, particularly unaccompanied minors. We do have a law that states that minors have to be registered with a public health pediatrician. But since in Italy we do not have one national health system, rather we have 21 different regional health systems, this in practical terms makes this right non-existing for vulnerable people such as children or the elderly people. In all our clinics, we started to have community nurses clinics because we do have a free of charge access to healthcare, particularly at hospital level. But when these people are dismissed from the hospital, are discharged or sent back home, there is no community level system that can take care of those people. And particularly the economic barrier is becoming more and more an issue. So we are starting from, we moved from a system that was universal, free access, and now step by step we are privatizing most of the services. Unfortunately, starting from the basic services, all the diagnostics, all the follow-up services, psychological support, dentistry. It's a big, big, big issue in Italy because it's mainly privatized. Just an example, we had the first patient of our clinic in Marghera, so it's Venice, one of the richest regions in Italy. He was an Italian person who in the 70s was a member of the Olympic team. Then his life went upside down, he lost a job, he divorced and so on. He got a problem with his mouth, started to lose the teeth, and he could not access any public service to fix it. So he became malnourished, he could not go to interviews to get a new job, and this was a huge problem for him, and we see many of these cases. 20% of our patients are Italians in this situation. And COVID, the COVID pandemic even brought it further. We really realized how important it is to, when we talk about health systems, how the perspective to start from taking care of the most vulnerable will also benefit the rest of the population. This is what did not happen in Italy, at least, but we have seen it also around the world. And I think that if we start thinking that healthcare, as we said before, it's not a silos issue, but is something that is really related to the well-being of each of us, so the contribution of all the different sectors of community can contribute. Once we agree on the principles, I think that we could definitely improve the access to healthcare and the quality of the healthcare that is provided. At least this has been our experience.
Merci beaucoup, Rossella Amici. Alors, justement, vous parliez de la crise Covid.
Thank you very much, Rossella Amici. You were talking about the COVID crisis. Let me get back to you, Sylvie Briand. You've been monitoring this crisis very closely. We talked about the difficulties for healthcare access in our systems. What did this crisis worsen, so to say, and what lessons can we draw? Well, what we saw through the COVID crisis was dual. First of all, for epidemics, there are several issues. First of all, transmission, how the disease circulates. And the second major dimension is mortality. We saw with two recent crises, the monkeypox, which was highly transmissible but not really deadly. This did not worry people so much. So we will have other epidemics because people move around, and when people move around, there's a lot of international travel, and there's a lot of risk of transmission. So it's important to get ready for that and to understand that one of the main issues in the COVID crisis was that governments realized that the healthcare system is a real protection in case of epidemics. Thanks to this system, you can reduce mortality. People who have these diseases have to be taken care of very quickly with quality care, and which leads me back to what was said about access to drugs. So in case of pandemic, it's not for the people to go to the hospital, it's for the health services to support people and to go to people so we can reduce mortality, which is the reason why WHO, even before the COVID crisis, had tried to revive the notion of primary health care, a notion that was launched in Alma-Ata in 1978. Another global conference on this topic was held in 2018 again. And in order to have this different vision of healthcare, unfortunately, in English, the notion is primary health care, and when you translate it into French, it sounds like primary sounds a bit cheap, when it's not at all the notion, because the idea is to have quality health care and a holistic vision, not only take care of people who have diseases, but also take care of prevention with vaccination. How can we make sure that vaccination is integrated into the healthcare practices? And when you talk about primary healthcare, this is something that has to be strengthened in order to reduce mortality in times of crisis. And I believe that if people had access to care, you would have a population that is in a better health situation. The population would therefore be more productive, which is very important. And when you have a good performance of your health service, you have a better social cohesion. If you look at the way the crisis was managed in Japan, where the primary health care is very good quality, with a very speedy distribution of drugs almost at home, they had a very low mortality rate, and the country got out of the crisis with a much better social cohesion. So this should be integrated in the health policy. Talking about vaccination, we talked about when we prepared this session. We talked about people refusing to get vaccinated. We were lucky with this epidemic to have very quick vaccines that were available. And you said when we were talking about refusing vaccination, you said that in our modern society we seem to have forgotten some diseases and forgotten about the risk of death. Yes, this is true, because as children don't die as they used to, people say vaccination is of no use. But you have to see that what we gained in terms of life expectancy was due to the fact that we were able to vaccinate people like measles. We can prevent measles. Obviously, there are side effects of measles that can be very serious, like encephalitis or yellow fever, for example. At the beginning of the 20th century, the yellow fever killed lots of people, and we can see that now with global warming, mosquitoes are reaching some parts of southern Europe. We even saw the transmission of dengue in the region of Toulouse. So we know that some of these diseases can come back, and the eradication and control of these diseases had a major impact on the population. So do we need a campaign of communication or public health campaign to explain that to the population? Reply, well, I believe we should commit and engage the carers and in these campaigns, but unfortunately the shortage of health agents means that they have no time to concentrate on that. And the problem with primary health care is the prevention. The whole fabric of health agents must be able to promote this prevention. Thierry Hulot, you talked about innovative and new drugs. Regularly, some physicians or patient associations say that these medications are available too late in France. Do you agree with that, and how can you explain it? Unfortunately, it's something that is true. I was telling you earlier about the Observatory for Access to Drugs published by LIM. What do we see? Well, we see that in France. If we look at the whole of Europe, France has a longer time to market of medications, because the process is very long. Once you get the authorization for the whole of Europe, we have to check whether this medication is sufficiently beneficial to be accessible for the French market. And then it takes longer than in Germany. Once you've done this, you have to negotiate a price. We see that the time it takes to negotiate prices is getting longer and longer. And then there must be a decree so that the medication is covered, and this has to be published. So we would think it would take 3 days. The average is 100 days. 100 days just to publish the agreement. Do you have explanations? Well, the explanation is that the administrative system is complex, but things are getting better, or are going to get better. But it takes 15 days more than in the past year, than last year. So there's an over-interpretation of European laws, so that France is losing ground, really. We remedied this partially with the processes for early access or direct access. So nowadays, if you have a marketing authorization for Europe, after an assessment with the health system, and you can sell on the market at the same time as you follow the administrative process. So it has accelerated the process for very new and novel medications. But last year, this only was beneficial to 51,000 patients. And that's nothing. So the problem is the attractiveness of the country. In 10 years, we have kept the same budget for reimbursement, but we have a lot of new pathologies that can be treated. We have very high ambitions. The French president a while ago said that drugs shouldn't be the adjustment variable of the budget of health policies. That's all very well, but for 20 years we've been doing the reverse. And in 2023, the budget of the social security is exactly the reverse, and this is very detrimental to safety and security. We talk about personalized treatment that can treat invalidating diseases, chronic diseases like hepatitis. Plant to build Ecarticel will represent several millions of euros. Why do it in a country like where the report that was published by the Social Security the day before came up with a new idea saying, let's reinforce a system which everybody agrees doesn't work. So medications that are not innovative, we're going to reduce the price, even though those were short. We had a shortage last winter. And the new ones, we're going to save on them, even if they represent a plus, a benefit. How can you attract research in such conditions? You have to reconcile your ambitions with your means. Otherwise, in 10 years, we'll still be here crying. Well, you talk about personalized medications and treatments. We are now starting this new system where a medication is adapted to the metabolism of someone, their antecedents, their personal history. It's difficult in this case to try and organize trials with great cohorts. I understood that you're battling with the sanitary authority to gain access to these personalized treatments. Well, let me say things differently. There has been a lot of divergence because the health authorities and the medication system have a different approach with for the phase 1, phase 2 trials, and with very wide criteria. This is what we used to have in the last century. And for some pathologies, it's not possible because we do not have the right number of patients. So for early access, we can remedy that, but we end up in a dead end because we give them early access, and then one day the commission evaluates that, and they say, okay, we haven't got enough data to pay you back and to reimburse, so we're going to stop it. We met with the new president of the High Health Authority, Lionel Collet, who is aware of this, and he's going to make some proposals. But when we have a main topic, which is to renew hope, I may not be renewing hope for you. I'm not saying there's no possibility. I'm saying you must have the means of your ambitions. Eric Momi, one word about prevention and the use of data. It's a major challenge. We all say that one way or another, we don't have enough prevention. We have to improve that in our health system. My opinion is that we do not have enough prevention, but we don't do it properly. We invest 15 billion every year in prevention, 6 billion with public policies that have trouble reaching their target. Let me give you an example. When we have a campaign about the fact that you should eat 5 fruit and veg every day, it only talks to 15% of the population. The others don't understand what you mean. So we have to improve the system. We have a system that is there to cure people, but not to make sure we have people in good health. So what can we do? First thing, we must help the public authorities to reach the objectives that have been set. At European level, there is an objective which is to have 70% of women over 16 years old vaccinated for VPH. And the figure is only 36%. And the same for colon cancer. We are not in the average of the European population. We are lagging behind, so we have to help the public authorities to complete this action. What can you do for the public authorities to help them? Well, what we can do is that we are in close connection with the patients. The national health system is in contact with the patients. But as I was saying earlier, we saw that what the French president added for prevention is only part of the program, but it's not something that is done in the field. We have now a group that is working on behavioral sciences for health to bring people to prevention. There's several leverages. There's school. There's also a campaign at 25, 45, and 65-year-old. Is the consultation for young adults at 25 the right age? How can we reach all publics, and not only the digitally minded, because some people are not digitally minded and cannot be accessed that way. So there's the issue of health at work, for example, vocation. This is a great place to work. The musculoskeletal disorders are something that the occupational system is taking care of, for example, and we can work on all that. Let me see with you, Rossella, with emergency, you also intervene in conflict areas with pediatric care, cardiac surgery. You're talking about Iraq, Yemen, Afghanistan. You were in Sudan when I talked to you to prepare this session. We can imagine how difficult it is to give access to healthcare to populations in these places. In practice, what are the obstacles you meet with?
First of all, I would agree very much with what Joanna was saying at the beginning, that we have several challenges. The geographic challenges that implies, and the technology challenges as well, that implies really worsening of the inequalities, and we have seen it over the past few years. The best example is our conversation when I was in Sudan. I mean, it was really very difficult to get a normal conversation. So when we talk about the future and the technology developments in the health sector, we should also not forget that we live in an unequal world in terms of access to these technologies. And this should be always in mind, because with COVID pandemics, we really realized that healthcare is a global issue. We live in a global world, so definitely we have to take care of everybody, if not exactly with the same level of care, but trying to go into that direction. And this is what we have been trying to do in many different contexts, even during very hard outbreaks. Sylvie was mentioning Ebola before. We have been working during the Ebola outbreak in Sierra Leone And we, as an NGO, set up the only intensive care unit for Ebola in all the Western African countries. And this was an important sign given to the healthcare workers of Sierra Leone, because what they were seeing was that when an international staff was getting Ebola, he was immediately medevaced to Europe. And what was left for them? Let's say second and third level care. And this was something that put them on strike. A lot of people in a country that has already a ratio of healthcare workers population very low, one of the lowest on earth. Many of them, they died because of lack of protection. So these are the different challenges that we face in terms of supplies. The supply chain is a big, big problem. But again, I do believe that health is a political choice. And if you think that to healthcare, or access to healthcare as a basic human right, that we have to find a common way and the resources and analyze how do we use these resources. Because for sure resources are scarce, but we are told too many times that high-level care, quality care is not feasible for everybody, but we never, because our resources are limited, but we never really focus on how do we use these resources, what are the priorities. And I think that this is a big challenge. Opening up this discussion is something that is pretty much needed now more than ever, because the contribution of the different actors are fundamental. We as an NGO believe in the right to health care, and we are trying to practice it daily in context at war, where hospitals are becoming a target. And so there is also this extra burden.
Et vous parliez aussi des checkpoints et de la nécessité de...
You were also talking about checkpoints and the need to remain neutral when you're in a conflict zone.
Now in Sudan, for example, where there is a new war, a civil war going on since 15th of April, we have seen it everywhere, from Afghanistan to Iraq. In Iraq, during the battle for the liberation of Mosul, the ambulances were stopped at the checkpoints, and patients, many of them, they lost their lives because the referral to the hospital was delayed, and this is something that is not possible, not bearable in 2023. But again, I really believe that going back to the idea that healthcare, access to healthcare is a fundamental right, so it's a responsibility of every single individual, starting from government to public sector, to private sector, to NGOs, to the science, universities, academia, to find a way to develop systems that are more equal worldwide, including in our communities, because we have seen that also in the rich countries, inequalities based on the wealth of the people are growing. And this is the only way we can build, I think, a sustainable future for everybody. Investing in the training of healthcare workers. That Sylvie was rightly saying that there is no access to healthcare without healthcare workers. And this is a big, big, big lesson that we should work on, I think.
Merci beaucoup. Alors, beaucoup de choses. On va devoir s'arrêter là, mais je...
Thank you very much. We're going to have to stop, but I would like to give the floor to the audience if you have any questions. Can you give a microphone, please? Sir. The microphone is not on, apparently.
Dr. Bruno Sienkiewicz.
Dr. Bruno Sienkiewicz, I'm a surgeon, a dental surgeon. My message is for all the participants, Mrs. Habib in particular, Mr. Mouni, and Madame Brion, and Madame Michaud. It's with great pleasure that I listened to you, but it's not the core business of my profession, really. I'd like to talk about my own personal experience. I have a twofold experience, both as a wage earner, a salaried worker, and as an independent. I've worked for the RATP of France with mutualized networks for health. The aim was to care for a maximum number of people. We were paid per hour. We had to care for a maximum number of people within the network. That was the aim. You offer this care to all the people who belong to certain big companies, certain big groups. And then the paradigm changed. Now I'm in private practice, and I was used to caring for everyone at large. I continue to work on the basis of this principle. I work with senior citizens and many groups of population. With data and modern technologies, you can care for a lot of people with implants and all sorts of other devices. We offer a top quality service with these implants, but you end up with fewer people. So, okay, you do things according to modern technology, but you can care for fewer people. So when you talk about this kind of new management, dental care calls for a lot of equipment and material. People prefer to set up their practice in the south of France or in big cities rather than going to the medium-sized towns. So what's your question? Get to the point. My question is for Nicolas Dufour, who's not present. In 2020, I was told that there was no need to take out a special insurance plan in my health insurance, and now I have a condition which is extremely costly, but I don't have this private healthcare system, healthcare contract. So how am I supposed to meet the cost? It's several tens of thousands euros. This is called provident insurance. That's the whole purpose. I'm not familiar with your problem, but doctors in private practice, when they have a health issue, they can then receive coverage with that kind of provident insurance policy. Perhaps we could refer to treating the largest number of patients or taking your time to provide top quality care. I'd like to react to what you said. We have noted the same thing, just to sum things up in a nutshell. We find ourselves in the dilemma you've mentioned. You talked about how to manage health properly. The Scandinavian countries have invested unlimited sums in their health system. It's very virtuous. It's a state system. Why? Because there's a lot of prevention. The issue is who's going to finance prevention. It's in whose interest to finance prevention. Caretakers are paid per act and others per volume. So you have to change the paradigm, perhaps. I don't think we can provide an answer here. That's one of the major challenges of our government today. You can care for hundreds of thousands of people when they have acute pathologies, but this is floods the health system, and we can't contend with such numbers as we encountered during the epidemic. The same applies to dental health. Thank you very much. I think we'll give the floor to our coordinator to sum up things. It's very complicated to sum up this session, which was covered a wealth of topics. I think we have certainly pinpointed the major challenges, the challenges where action needs to be taken now in terms of primary health, the pharmaceutical industry. That will condition access to care in the future. If we are to reconcile all the strategic ambitions and the means available, I think we have to forge ahead. However, perhaps just to finish on a more hopeful note, a number of speakers have referred to certain levers: prevention, enhancing the value of the career of caregivers, the importance of therapeutic innovation and access to these innovations, simplified access, technological breakthroughs. Look at telemedicine, teleconsultations. They indeed will play an extremely important part when it comes to providing, and they did, to provide continued care during the pandemic. So we have the challenges, we have levers to act, and I'd like to thank all our speakers. I think we can give a round of applause to all our speakers this morning. And we wish you a very pleasant day at this meeting.